Good morning, everyone. Thank you so much, ma'am, for a wonderful introduction. Thank you so much. And here we start on day 2 after our great sessions, yesterday's sessions of wonderful senses of talks. So here we start with it. I'm opening with my talk on infertile couples. It would also be titled, yesterday's opening was make love, not babies, but I would say today I'll say make love, but also babies. So for a newly married couples, that would be my talk for today. As far as infertility is concerned, am I audible and visible properly? Yeah.
Yes, madam.
So as far as, so we are starting with this evaluation of infertile couples. Why? Because incidence is increasing nowadays. So there are many cases, like 1 out of 6 couples is suffering from infertility. And its incidence is increasing because of late marriages, career settlements, then the use of contraceptives. And it needs to be treated properly, as these couples are always like that. If there is an infertility, there is always a social pressure, and so a proper counseling forms an important role in these couples. So what is infertility? We define it as it is inability of a couple to conceive naturally even after 1 year of cohabitation, which is regular cohabitation without any use of contraceptive. This can be reduced to 6 months if a female has if her age more than 35 years, or if she has she's a known case of ovulatory disorders like PCOD, or any severe endometriosis, or any ovarian surgery, or a history of genital or abdominal cocks. Briefly, as we know, there are 2 types of infertility: a primary and secondary. Primary, we would say, primary, it is there is no obvious previous pregnancy. Secondary would be there was a previous pregnancy, but not necessarily a live birth. So it can be a miscarriage or ectopic pregnancy, or a live birth, but now the couple is having problem in conceiving. That is called as secondary infertility. So the factors, the causes for this infertility needs to be evaluated. Causes generally account for, it is generally account for, like male infertility accounts for 30% of the causes, female account for around 30%, combined, like both male and female, it accounts for 10% of the causes, unexplained are the 25%. So before understanding how to evaluate these couples, we need to understand how conception.
Sorry to interrupt, ma'am. Will you please share your presentation?
Should I share? It's not getting shared.
No.
Oh. Sorry for the
Yes, it's visible now, ma'am.
okay.
Yes.
Yeah, thank you.
Yeah. Thank you, ma'am. Thank you for that.
Yeah.
Text. Yeah. So understanding for understanding how to evaluate these couples, we need to understand how conception takes place. So just a revision on it. So as we know, it's egg plus sperm, that is equals to baby. So what happens is the conception of fertilization, how it takes place. Whenever there is a hormonal impulses which takes place, then after that, female, as we all know, has a uterus, 2 fallopian tubes, and 2 ovaries. So whenever there are hormonal impulses takes place, the oocyte, the egg is released from the ovary, and then it is captured by the fallopian tube. Here, the egg stays for around 16 to 18 hours. If suppose a cohabitation takes place or a coitus takes place, and in around that period, then the semen is collected in the vagina. The sperms, they travels through the uterus, and they go to the egg in the fallopian tube. Egg and the sperm, they meet, and these two cells, they form embryo. So embryo, that is two cell embryo, it divides into 4, then 8. After that, for after 3 days, the embryo gets implanted in the uterus, and it grows again, and it takes a form of a baby, and after 9 months it delivers. So this is how conception takes place. So any problem in this process will result in infertility, and these couples then require a proper evaluation and treatment. As far as male are concerned, they also have a pituitary gland, hypothalamus, and the hormonal, whenever there are hormonal impulses, that will lead to the sperm formation in the testes. They have two testes, then they have a penis. After the hormonal impulses are there, the sperms, they form in testes. They then travel through the vas deferens, and after that they go through the penis and gets deposited in the semen sample. So if we have any problem at this level, so what will be the causes for infertility as far as male is factor is concerned? If the hormonal impulses are not proper, if there is a local cause like testes, that is, or any infections, any history of cancer or radiotherapy, any injury to the testes. I won't be going in details of the causes of this infertility, as my topic is evaluation, but we need to understand any hormonal problems or the local causes, or if there is a vast difference is absent, or this vast difference is blocked, then also in these cases the formation of sperm is there in the testes, but it doesn't come out in the semen. Such cases are termed as azoospermia. So many couples we see there is azoospermia, but these couples, if we evaluate them properly with the hormonal testing, if we do get the chance if their hormonal profile is normal, we can get the sperms in the testes by a process called as testicular sperm aspiration. So as far as female is concerned, her causes would be divided into 4, like the hormonal problems, ovarian problems, the fallopian tube problems, and the uterus problems. So ovaries, there can be a PCOD or a diminished ovarian reserve. Tubes, fallopian tubes, it can be if it is blocked or there is a hydrosulfings, that will lead to infertility. Or in uterus, she might have a small uterus or a very big uterus, that is adenomyosis, or any fibroids, any endometrial adhesions or polyps. Generally, in India, we say tubal causes account for much of female infertility. So proper evaluation of these causes is the most important thing to get the accurate diagnosis and to have a precision in our treatment. Generally, the common mistakes which are made while evaluating a infertile couple is generally the couple is not seen together. So the wife comes with the mother-in-law, and they generally start with the treatment, but the husband actually it accounts for around 50% of the infertility. Semen analysis is not performed, and then we come to know there is a problem in the semen analysis. So investigations should be done for both female and male partner equally. And another mistakes which is done generally is investigations are performed in piecemeal fashion. So one day we perform the semen analysis, or in the next month we perform the blood test for the female. That's not the way it should be done. It should be done as a part of overall strategy. Generally, couples keep on changing the doctors after taking small treatments, and they keep on changing the doctors with repetition of investigations, which is just wasting their time and money. So we will be seeing this evaluation of infertile couple topic in these three categories. A detailed history of these couples is important, then examination of these couples is important, and investigations are important. And history, maximum times history will give us the proper the cause for these infertile couples, for why they are not getting pregnant. So it is very rightly said by Renee that listen to your patients, they are always giving you the diagnosis. detailed history of this couple. So as far as history is concerned, uh, we have to see the age of both the partners. So many a times age is, if it age is more than 35 years, our management would differ, our plan for investigation would differ. If the age is less than 30 years, the management and plan will differ. So age is important. Then occupation should be taken into account. Why? Because many of times, now at times, it is that the female and male both are working, and so they hardly gets a time to come home. They hardly has a cohabitation, and all this will lead to infertility. Also, some occupational hazards are there, like working too much in heat, working too much in front of laptops and computers. That will also affect the semen parameters in a male. Then second thing we have to look is duration of infertility, that is without contraception. Many times if the couple is married for 6 years, but couple doesn't try for 5 years, and then he or she is trying for 1 year. So we have to take into account the duration of infertility. Detailed history of the couple should be taken. For the wife, menstrual history, suppose she has the menses are irregular menses, so we can get an idea about any diminished ovarian reserve or PCOD. Then how bleeding takes place, so any history of abnormal bleeding while coitus, that will also tell us about any polyps or any fibroids in her. Obstetric history should be taken, her medical or surgical or past medical or surgical illnesses, so that she should plan the pregnancy safely. Her drug history should be taken. Then a coital history should be taken in detail, that is how they are planning, what is the frequency of the coitus, is there any dyspareunia, that is pain or any discomfort while having sex, erectile or ejaculatory dysfunction. I won't be, of course, taking erectile or ejaculatory dysfunctions in detail. We'll be taking it in the next sessions. But coital history is very important, as timing is very important, as egg when released in the fallopian tube, it stays only for 16 to 18 hours. And so the sperm should be available there for that couple to get pregnant. So timing is very important, which should be done between 10 to 18 day at the time of ovulation. Then detailed history will also comprise of any use of eye pills or contraceptives, any history of thyroid illnesses or any pelvic inflammatory diseases. Of course, one more history which should be taken, that is a history of addictions, alcohol, smoking, drugs in a couple. This also leads to infertility. Any family history of early menopause and developmental anomalies. As we all know, now age is the biggest factor which is causing the infertility because of increasing trend of late marriage. So our previous like our grandmothers, they used to tell ki get married soon, or get your baby soon. That was a good thing. Maybe soon means after, of course, after 18 to 19 years, but that was a good thing because there is a biological clock for every female. So the fertility is good between the age of 30 to 20 to 35 years of her age. If they're getting married late and career settlement they have to do, then this is showing a increase in the infertility. Generally, substantial decline in fertility begins between 35 to 40. In Indian women, it is said it is 6 to 7 years earlier. But now I can say, thanks to assisted reproductive techniques, IVF technologies, we are having. So girls who want to get married late, they can go opt for oocyte freezing, or they can who are married but wants to settle for their career, they can go for embryo freezing, and then they can plan their pregnancy after 35 or so whenever they want to. So many of the girls are now coming to us, they're getting their oocytes freezed because there is a biological clock. So when you have the best oocyte quality, they freeze those eggs, and afterwards they get married, and afterwards we can just combine their husband's sperm with those eggs. and then they can get pregnant. So this is increasing, of course, but that is of course a thanks to this ART technologies. These embryos or eggs, they can be freezed for years together. Examination of couple is very important to look for BMI, weight. If the female or male partner are obese, then we need to tell them to have a proper lifestyle modification with a weight reduction, so that the ovulation, many times females do conceive with weight reduction, around in 75% of the times ovulation takes place in them. Then of course pulse rate and blood pressure should be examined for these couples, so that if she is having a hypertension prior to opting for the pregnancy, she can be treated priorly. Then in wife, specific signs which can be seen are the signs of androgen excess, that is hirsutism. Many times a female is there who has acne, hirsutism, facial hairs. All these things we can get an idea about if she has having a PCOD or any other hormonal disorder. Her detailed per speculum and per vaginal examination should be done. Then in husband, we can see for signs of androgen deficiency. So if a male partner is there who is not developing the beard or the mustache, they just do have some sort of deficiency, androgen deficiency in them, and we can get an idea about what is the cause of infertility. Smell sensation in husbands for Kallmann syndrome, then gynecomastia, external genitalia and scrotum examination should be done in these male partners. Of course, as far as investigations are concerned, if we see, basic investigations should be done for these couples, not repeatedly, but of course as a part of overall strategy, that is complete blood count, blood group, the serology, blood sugar, we are generally performing hemoglobin electrophoresis for husband and wife to see for any sickle cell or thalassemic traits or the disease, so that we can give the couple idea about what can be done for the baby. Then specific tests which are done for wife, we are performing in the hormonal now, FSH, LH. Previously it used to be FSH, D2, FSH, LH, then TSH, but AMH, anti-Mullerian hormone, now is giving a better idea for oocyte quantity and quality. So we are performing thyroid stimulating hormone, as if TSH is low or high, it can lead to infertility. Prolactin levels and AMH in this wife. Some other tests like liver function test, kidney function test, rubella, IgG, IgM, pap smear. If the age is more than 35 years, ultrasonography of the pelvis is important, and hysterosalpingography and sonosalpingography. We'll be seeing this in just a quite detail. As far as husband is concerned, a simple single test, semen analysis, would help us to check for the cause of infertility. As far as male factor is concerned, some other test, if we find something in semen analysis, simple test, then we can go for DNA fragmentation test, hormonal test, genetic testing, or ultrasonography. I would say this can be a 1 month strategy for these couples. A cost effective testing strategy must be followed for a couple, and we generally follow 1 month strategy. So we do semen analysis during wife's menstrual period, so they have a proper abstinence of around 3 to 5 days. Then we do blood test on day 3, so I can get a better idea of prolactin. AMH and TSH can be done on any day of cycle, but of course prolactin needs to be done between day 2 to day 4. So we do this blood test on day 3 of her menstrual cycle. Tubal testing needs to be done on day 5 to day 9 of her menstrual cycle. Of course, and ultrasound monitoring of ovulation, that is ovulation is happening or not, the egg is getting released or not, from days 10 to day 16, till we find the egg has ruptured or the follicle has ruptured or not. If we go the basic details of this, as I said, it is 8 plus sperm is baby, but mainly as far as infertility is concerned, we need ovaries at a proper stage, the semen at a proper semen should be proper, uterus and fallopian tube should be proper. So to get proper, because conception is yet a simple, but it's amazingly a complex process, and one can have problems at microscopic levels, and that's the reason for their infertility. So many times we find a couple, they have all the reports are normal, but they are infertile. So in these couples, we need to get into the details, microscopic details of these couples. So as far as I have said, semen analysis needs to be performed. Semen analysis, or sperms, semen is seen as after the abstinence of 3 to 5 days, semen is collected from the husband. Then it is visualized under the microscope. A normal sperm looks like this. It has a head, a neck, and a tail. So they should be normal. What are the parameters we take into consideration? Are the parameters, its volume. The semen volume should be at least 1.5 ml or more. This is according to WHO 2010 criteria. The count should be 15 million or more in 1 ml of semen sample. The semen will have sperms and its count should be at least 15 million. So it is in millions, but at least it should have a motility. So how much motility? We say 32% should be at least progressively motile. Total motility should be 40%, but actually we want this progressive motility to be there, so as the sperm should travel to fallopian tube. One more thing which needs to be seen is sperm morphology, which is many times missed. Sperm morphology needs to be checked properly, as sperm has head, neck, and tail. I had a couple with 7 miscarriages. Semen count was okay, motility was just low, but okay, and they were evaluated for everything, but the pregnancy was not happening and it was leading to a miscarriage. Then we evaluated the sperm morphology properly, and we found that there was a 0 sperm morphology, so which was the cause of her miscarriage. We treated her and she has now a healthy baby. Morphology we count on this Mechler's chamber. Here we take like a semen drop is put, and we count these sperms in squares, and at least 100 sperms are counted, and we see for the semen morphology. Other optional tests are in case of, if we have, so I have said the count should be at least 15 million. So if it is less than 15, it is oligospermia. If motility should be more than 40%, if it is less than that, it is termed as asthenospermia, and morphology should be at least 4%. If it is less than that, then it is termed as teratospermia. So if there is severe oligoasthenoteratospermia, or in cases of unexplained infertility or repeated in vitro fertilization failures or recurrent pregnancy losses, a DNA fragmentation test can be performed in this husbands, and we can get a better idea. In case of in the males with severe oligoasthenoteratospermia or azoospermia, a detailed endocrine evaluation is needed, that is serum testosterone and FSH. Genetic evaluation is sometimes needed for karyotyping or YQ microdeletion, and scrotal ultrasound can be performed in these husbands to see for the testes and their place, their size, and other parameters. This is as far as eggs or sperms are concerned. Now, Now we'll see for the eggs. A normal oocyte looks like this, healthy oocyte. So if we see microscopically, if we remove the eggs, it will be seen as this. And in this egg, the sperm enters and then forms the embryo. So we have to check for the egg quality. Of course, exact egg quality we will know after removing the eggs, that is after ovum pickup only in ART procedures. But we can get a fair idea about how the egg is. So it will be divided into two, that is test for ovarian reserve and test for ovulation. So ovarian reserve, we can get to know with a simple ultrasound, that is antral follicular count, which can be done on day 2 to day 3 of the menstrual cycle of a female. This is a normal picture of ultrasound, normal picture of normal ovarian reserve. We can see more than 5 to 6 follicles in this. So this is a normal normal ultrasound picture. This is a picture of diminished ovarian reserve. We can see only single follicle. So this is a picture of diminished ovarian. So normal ultrasound on day 2 or day 3 of a female can give us a idea about how much reserve she is having. If it is more, if they are peripherally arranged around 15 to 20 oocyte, then we call that as a polycystic ovaries. AMH, anti-Mullerian hormone, I would just like to say ki it is first for ovarian reserve, we are seeing 2 tests. One is antral follicular count and the second is this anti-Mullerian hormone testing. It is a very simple blood test and it is a direct marker of primordial ovarian follicle pool and should be offered to these females. Its normal range is generally, it varies between 2.5 to 5. Anything less than 2.5, we would say diminished ovarian reserve. In that case, if less than 1 it is there, it gives a poor outcome in case of infertility treatment. If it is more than 5, we can label that as PCOD. So this is the importance of anti-Mullerian hormone. It is a very good test, and it is now we are doing it generally for young females who wants to go for egg freezing or also to know the ovarian reserve. Other tests are also there to detect the ovarian reserve, but I would say 2 tests are important and they will give us a fair idea, that is anti-Mullerian hormone and antral follicular count. Test for ovulation, there are 3 tests we can say majorly. One is folliculometry, that is by simple ultrasound. We must have seen the follicle chart in this infertile couples. We start with the serial transvaginal scan. On day 10 of the day 2 scan should be done actually in these females to rule out for the cyst. So if there is a cyst, we can just cancel that cycle and take care in the next cycle. So day 2 ultrasound is must. Then we have to do this from day 9 to day 10, and we see for the egg rupture, generally a free fluid in the pouch of Douglas or collapse of the follicle will give us an idea about the follicular rupture. The second test we would say is the serum progesterone. We can do it on day 21. If it is more than 3 nanogram per ml, then it is predictive of ovulation. It is simple 1-point test. Then another is urinary LH surge detection test. Now we get online or the in medical we get this LH kits which can detect the LH surge, and accordingly we can tell the couple to plan their contact so they have a better results. It should be planned, as I said, oocyte 1 released, it stays only for 16 to 18 hours. So 1 day prior, on that day and another day, they should be planning. So if the egg is getting ruptured on 11th day, they should plan on 10th, 11th and 12th. They should have a coitus to get pregnant. Third important thing in this evaluating these infertile couples is the uterus and the fallopian tubes. A simple ultrasound, transvaginal ultrasound, 3D transvaginal ultrasound will give us a fairly 99% of the times we can get a fair idea of what is there in the uterus. Laparohysteroscopy is not always needed to diagnose any situation. So majoritarily we can get an idea on USG pelvis for uterus. For fallopian tubes, of course, hysterosalpingography or sonosalpingography can be performed to check for its patency. As far as hysterosalpingography is concerned, as we know, it is a radiologic visualization. In this, it is done on day 5 to day 9 of the menses, and in this, a dye is injected in the cervix, and we can see these are the X-rays captured. So we can see a uterus. Then, of course, that once the dye goes in the fallopian tubes, and fallopian tubes can also be delineated. This is a picture of hydrosalpinx. So we can detect HSG is a good test, but we have to tell the patient that it is a painful test. We have to counsel the patient priorly that it is a painful test. Nowadays, we are performing sonosalpingography. So sonography is less painful. It can be performed with a balloon catheter, and the balloon catheter is inserted transcervically. It is distended with the saline, and saline infusion is done into the cavity. And radiologically, we can detect the patency of sonographically we can detect the patency of this tube. In this, it has got an advantage of the it has got an advantage that uterine pathologies are delineated properly. So if there is a polyp in uterus or any fibroid, they are delineated properly. So this is a sonosalpingography picture. As far as uterus is concerned, in ultrasound, we have to see for any congenital uterine anomalies. Then we have to see for fibroids or adenomyosis. We have to see intracavity any lesions in the uterus, that is polyp, or there are endometrial adhesions, or intracavitary fibroids, that is submucous fibroids. Endometrium needs to be evaluated properly in these infertile couples. So if we see a normal endometrial picture is this is a picture of a fibroid, and this is a picture of an adenomyosis. Fibroid will look like this, and adenomyosis will look like this. Sometimes this adenomyosis, it has got a typical ray appearance. Sometimes the adenomyosis is misunderstood for the fibroids, but we have to look for it properly. This is a picture of intrauterine adhesions, and this is a picture of a polyp which can be seen in the uterus. We need to remove these polyps before treating these couples. Endometrium is of course important. It needs to be properly evaluated on day 12, 14. Also, I would say 18 to 22 day of cycle also, to see, because embryo implantation takes place on those days. Too thin or too thick endometrial will result, of course, will result in infertility. Endometrial vascularization should be taken, it should be done, it should be evaluated properly. If there is a poor endometrial blood flow, then also these couples won't conceive. Laparoscopy and hysteroscopy, we would say it is not needed for as a complete to the workup as a couple. But if we find there is a abnormality or the tubal blockages or the hydrosulfing, then we can perform laparoscopy. Or there are uterine adhesions, the endometrium is less, then we can, or we generally perform it mainly for the therapeutic purposes, sometimes for the diagnostic. So it can't be considered as a diagnostic procedure for the evaluating these couples. Treatment of options, of course, this is not my today's topic. So I would say take home message would be counseling is an important part of management, and of course both the partners should be evaluated at the same time. So in this infertility, it is very important counseling plus both partners to be evaluation, and preliminary history should be done in detail. Cost effective tests are semen analysis, simple pelvic ultrasound with a folliculometry, and some basic blood tests with anti-mullerian hormone, thyroid stimulating hormone, prolactin, and hysterosalpingography or sonosalpingography for tubes. Of course, these couples are generally stressed out, and they need to be ensured by proper counseling. They need to be told, do it properly, and unnecessarily do not waste time and money by changing the doctors. Do it properly at one doctor, and it takes patience. It requires patience, and after that they can definitely, by this way or that way, they can get pregnant. Simplified approach will lead to the significant reduction in both time and cost of investigation of an infertile couple. Of course, I would also like to say we are doing it simplifically, and this couple needs to be told that the science has advanced so much that we have assisted reproductive techniques, we have egg freezing, embryo freezing. They can take a help of it, and after that they can afterwards their career settlement and age, they can get pregnant. But it is always better to be safe than feel sorry. So many times the couples do abortions, MTPs, in earlier months of their marriage, and after that they come to us that they are not getting pregnant. So they need a proper counseling. It is always better to be safe than feel sorry. And pregnancy take home baby rates will of course decline with increasing age. So they should take a help of assisted reproductive techniques, may it be an IUI or IVF, earlier than late. So this is all about my today's session. Thank you so much for the patient listening. So I would say yesterday's talk started with uh, it was make love, not babies. I would say today's topic will start. I want to start it with make babies also with love. And any questions, if you have, feel free to ask. And thank you so much for organizers for letting me give this session. And thank you so much participants for patient hearing.